would like to introduce our speaker for today, Dr. Roshni Patel. Dr. Patel obtained her Doctor of Pharmacy degree from St. Louis College of Pharmacy, and she currently practices as a clinical pharmacist at U Chicago Advent Health in Hinsdale, Illinois. Dr. Patel, thank you for joining us today.
Thank you for having me. Today, I'll be discussing the COPD ever-evolving disease. I am a clinical pharmacist at University of Chicago Advent Health. I work both in the intensive care unit and as an internal medicine pharmacist. So I believe COPD for me is kind of an evolving disease where we go from exacerbations to having patients who are chronically managed with inhaler therapy. So some of the disclosures I have is that I have no conflicts of interest to disclose related to the content of this presentation. So the objectives of this activity include list the diagnostic criteria, risk factors, and presentation of patients with COPD, outline the pharmacotherapy treatment options for patients with COPD, and identify the changes to the updated COPD GOLD guidelines from 2023 to 2025 for COPD management. COPD is defined as a heterogeneous lung condition that's characterized by chronic respiratory symptoms. So we have our shortness of breath, we have exacerbations, and sputum production with cough. And this is usually due to the abnormalities in the airway, so bronchitis or alveoli dysfunction, emphysema. And this is often a progressive airflow obstruction. So this is different from asthma, as patients usually have diagnostic risk factors, which is excess mucus production and cough, chest tightness, activity limitations, and even destruction to the alveoli. And this is a chronic airway inflammation and its injury leading to scarring. And then this also causes a diffuse airway narrowing that again causes airflow obstruction and then causes a mucus hypersecretion. And one of the biggest risk factors for COPD are cigarette smoking. So the epidemiology of COPD and why we think of it as a chronic important disease is that there's an estimated 3 million deaths annually due to COPD. Estimated 16 million deaths are diagnosed, 16 million adults are diagnosed in the United States. So anybody over 18 years old. And there's an increase in mortality due to the epidemic of smoking and vaping, and a reduced mortality from other diseases. So while we're improving our mortality on other diseases, our mortality for COPD is increasing. And then also this is an increased mortality also due to the aging population. We know that the boomers had in the 70s were smoking a lot more than I guess we are now. And also there's not a lot of modifying therapies besides different types of inhalers and a couple of oral options for COPD. In 2011, COPD was the third leading cause of death in the US, and the mortality was actually higher than women, even though we know that men actually tend to have a higher rate of smoking. And the COPD is often underdiagnosed, especially in the young population, and almost overdiagnosed in the elderly population just because of decreasing lung function as we age. And it's also associated with a higher healthcare cost and a higher economic burden. And then this is usually caused by a significant exposure to gas. So either cigarette smoking is a key factor. Also, key factors is if we have patients due to environmental. So a lot, if you live in California and you see a lot of wildfires, this could also be a risk factor for developing COPD later in life. And smoking is our number one modifiable risk factor. Smoking leads to inflammation and cell injury, eventually leading to a COPD diagnosis. Some signs and symptoms of COPD include dyspnea, which worsens with exercise and over time, cough, sputum production, chest tightness, wheezing. And on physical exam, you'll find shallow breathing, increased respiratory rate, and the usage of accessory respiratory muscles during breaths. And the diagnosis is by using spirometry. So we want, if the post-bronchodilator FEV1 FVC ratio is less than 70%, this confirms airway obstruction. So again, this is confirming a COPD diagnosis post-bronchodilator therapy. And then FEV1 is your forced expiratory volume in 1 second. So amount of air that a patient exhales in 1 second. And an FVC is the forced vital capacity. So our first knowledge check is AB is a 17-year-old patient with seasonal allergies. That's our keyword. Seasonal allergies presents to the ER after mowing the lawn with increased shortness of breath and chest tightness. Patient has a 1-pack-year history of smoking, but endorses similar symptoms in the spring or summer as a child. What respiratory exacerbation is this patient most likely experiencing? Our options are A, COPD, B, asthma, C, pneumonia, or D, an allergic reaction. It looks like our answers are in. Most people said an allergic reaction. Unfortunately, that answer is incorrect. B is our answer, which is asthma. The reason the patient has asthma is we have several risk factors here. The patient has seasonal allergies. The patient was mowing the lawn, so that's an antigen that can cause your asthma to exacerbate, and increased breath and chest tightness that we also see with COPD. Also, this patient only has a 1-year PAC history of smoking. So our answer is B, asthma. So again, a diagnosis of COPD is a post-bronchodilator spirometry. And then again, FEV1, FVC ratio has to be below 0.7, which is our hallmark sign of COPD. So if we have a post-bronchodilator therapy where we go from 0.5 to 0.3, that is considered COPD. But if somebody has a 0.9 pre-bronchodilator and we go to 0.8 post-bronchodilator, that is still not considered COPD because the FEV1 FVC ratio has to fall below 0.7 post-bronchodilator for it to be considered COPD. And then the GOLD ABE assessment tools used to direct non-pharmacologic therapy and pharmacologic therapy, so inhaler choice for our patients. CT scans are not your gold standard for diagnosis, but then they can help determine the etiology of COPD, whether it's emphysema or bronchitis, and also if it's progressing. And then it can also help distinguish between COPD and asthma or other types of respiratory infections, such as tuberculosis. So the evolution of guidelines. So every year, the GOLD guidelines come out for COPD, and these are gold standards for treatment of COPD. And there was a major revision to these guidelines in 2023. And in 2023, basically, we kind of changed the definition of COPD, where now we're saying it's a result of a series of dynamic, cumulative, and repeated gene environmental interactions over a lifetime. So there are certain risk factors like smoking that we can decrease over time to help reduce the incidence of COPD. And there's now proposed different types of COPD. So before we had a general term, patient has COPD, but now there's different kinds. So we have COPD due to genetic factors, which is COPD-G, and that's usually your alpha-1 antitrypsin deficiency. And then we have COPD-D, which is COPD due to abnormal lung development. So that's usually during childhood, and also environmental factors. And then we have COPD-C, which is the one that we see most often, which is due to smoking and vaping, and also as from secondhand smoke. And COPD-P, which is from pollution, so from wildfires and things like that, or hazardous workplace environments. And then also we have COPD-I, which is due to infections such as HIV and tuberculosis. And this is usually in the early childhood respiratory diseases. Also, there's a COPD-A, which is an abnormal lung development that's due to childhood asthma. So a lot of patients can have asthma and COPD. There's also a COPD of unknown cause. So patients that have risk factors, they weren't exposed to secondhand smoke, they weren't smoking, they weren't exposed to wildfire, but they still have COPD later on in life. And usually that's of an unknown cause. And there's very few patients that actually present with COPD of unknown cause. And then the ABCD assessment tool that was used in 2023 was actually updated to an ABE assessment tool. So it kind of went from 4 categories to 3 categories based on the patient's exacerbations and their shortness of breath symptoms. And then also in 2023, we shifted from a long-acting muscarinic antagonist, a long-acting beta antagonist, and triple therapy versus just using a long-acting muscarinic agent and a steroid. So steroid is not our first choice of an agent anymore. And then the guidelines for 2025 really put an emphasis on the pre-bronchodilator therapy. And then it also showed us how to manage patients with stable COPD. So vaccinations using the COPD guidelines, using the CDC guidelines. And then newly added medications, we have our phosphodiesterase 3, phosphodiesterase 4 enzyme inhibitors, and that's the ensifentrine. And that is actually only FDA approved, recent FDA approval in the US. And then we have our next agent, which is a dupilumab, which is a IgG4 inhibitor. It's a human monoclonal antibody, which we do see in the algorithm that we'll be presenting next. And then it also puts an emphasis on a multimorbidity due to cardiovascular risk. So it goes kind of into pulmonary hypertension, arrhythmias, and all these things that can promote shortness of breath and exacerbations in COPD patients. And then also it showed us some guidance on how to switch patients from long-acting beta antagonists plus steroid therapies to patients on long-acting beta antagonists plus long-acting muscarinic agents. And then it also revised recommendations on ICS or our steroid withdrawal. So anybody who has a eosinophil count that we know is likelihood to increase inflammation and increase risk of pneumonia is that these patients should or not increase pneumonia, I'm so sorry, but we know that this increases the risk of inflammation. So an ICS therapy should be added to these patients, which again can increase our risk of pneumonias. That's why we wait until the eosinophil count is greater than 300 to initiate steroid therapy. So the COPD assessment tool basically went from 4 categories to 3 categories. So it's based on, first you're diagnosing COPD based on the spirometry. So you have an FEV1 FVC ratio of less than 0.7. And then you're doing an assessment of the airflow obstruction. So depending on the grade, if there's the highest FEV1 grade is level 4, and that's where you have the lowest predicted FEV1. These patients are more likely to exacerbations and have an increased mortality risk. And then you're looking at the assessment of symptoms and a risk of exacerbations. So we have 2 different assessment tools we can use. We have the Modified Medical Research Console, which is a shortness of breath scale that classifies dyspnea in patients with COPD. And we also have the COPD assessment test, which quantifies the effects of COPD symptoms on patients' overall health. So when we look at the MMRC, that's basically looking at group A has less symptoms, group B has more symptoms, but low risk of exacerbations in the future. And then patients in group P have a high risk for future exacerbations. And then the CAT quantifies basically how a patient is, how they feel when they're walking, or if they cannot go out of the house without being shortness of breath, or they can't exercise without being shortness of breath. So when we have patients with a low risk of MMRC of 0 to 1, or a CAT score less than 10, they're put in group A. For patients with an MMRC greater than 2 and a CAT greater than 10, they're put in group B. And then patients who have greater than 2 moderate exacerbations or greater than 1 leading to a hospitalization, we automatically put that in group E because they will have high MMRC scores and high CAT scores. So just an overview of our pharmacologic therapy based on the 2025 guidelines is that patients who are in group A are usually started on a bronchodilator, and patients in group B are started on a long-acting beta agonist and a long-acting muscarinic antagonist. And patients in group E are started on a long-acting beta antagonist plus a long-acting muscarinic antagonist, plus they can be considered for steroid therapy with ICS, the inhaled corticosteroid, if the blood eosinophil counts are greater than 300. Again, the addition of ICS increases your risk of pneumonia. And then a single inhaler therapy, sometimes it's more convenient for patients than having to use multiple inhalers. So there's a lot of triple therapy inhalers out there for long-acting beta antagonists, long-acting muscarinic antagonists, and using ICS. One of the inhalers out there right now that we have are trilogy inhalers. And sometimes that is more efficacious for the patients because they're more likely to use 1 inhaler versus using 2 or 3 inhalers in a day. So if we go on to our group A treatment, for our group A treatment, we have 2 options. We use a bronchodilator therapy. So we can use a short-acting bronchodilator therapy for patients who have low risk of shortness of breath, who are not short of breath at baseline, who have symptoms intermittently. So we can use a short-acting beta agonist, and those are bronchodilators albuterol and levobuterol. One of the things is a lot of patients like to use Xopenex because of the risk of tachycardia, which there's a lot of studies that have shown that there actually is not an increased risk of tachycardia in patients with Xopenex versus albuterol. And then for patients who are still in group A or having more symptoms of shortness of breath and they're not newly diagnosed, our number 1 treatment is actually using a short-acting beta agonist for those patients with occasional shortness of breath and immediate symptom relief in patients on maintenance therapy. And then the thing about short-acting beta agonists is that it's rapid onset of action. So we use this a lot in exacerbations as well. And some inhalers include albuterol and levoalbuterol. Group B treatment is when we have treatment with a long-acting bronchodilator. Prior to this was a long-acting bronchodilator plus a muscarinic antagonist. So we have a LABA and a LAMA in all patients with group B treatment. And then your long-acting beta agonist this is for your maintenance therapy. So we have our formoterol, salmeterol, and we also have combination inhalers. We also have long-acting muscarinic agents for maintenance therapy. This includes our Spiriva, our Incluzalipta, and our short-acting, including Atrovent, that patients can use at home. Group E treatment has a couple different options where we have all of our patients on a long-acting muscarinic agonist plus a long-acting beta agonist, plus or minus using an inhaled corticosteroid. And we'll kind of go into in further slides, kind of go into which patients should qualify for an ICS treatment. In these patients, we consider a LAMA plus a LABA, especially for those patients who were previously on a LAMA or a LABA plus ICS therapy. And then in the hospital or even at home, we can consider duonebs, nebulizers, or a Neurolipta, which is a combination LABA plus LAMA. And then we consider ICS in addition to patients with an eosinophil count of greater than 300. And this place in therapy is for patients with frequent exacerbations that are not adequately controlled on LAMAs or LABAs, and they provide the greatest benefit in combination with bronchodilators in patients with eosinophil counts greater than 300, greater than or equal to 300 cells per unit a liter. Our next knowledge check is in an outpatient setting, a newly diagnosed COPD patient is complaining of increased difficulty breathing, but has not required any hospitalization. Which is the best inhaler option to start at this time? Okay, so most people said a short-acting beta agonist, which is the correct answer. However, I can also say B, long-acting muscarinic antagonist can also be considered as a optional B for patients who do have shortness of breath for longer than intermittent or have infrequent or more frequent shortness of breath. We can consider a long-acting muscarinic agent, but preferably for this patient who has not required any hospitalizations and is just complaining of this one-time increased difficulty in breathing, we should start with the short-acting beta agonist. And this short-acting beta agonist should be continued for no matter what category this patient will belong to as the disease progresses. So evolving from the 2023 to 2025 guidelines, and then we're evolving from LABA plus ICS. So previously, patients were on a long-acting beta agonist plus a steroid. And we found in recent studies that actually these patients should be switched over to a long-acting beta agonist and a long-acting muscarinic antagonist. So a patient who has a current exacerbation and their blood eosinophil count is less than 100, we should consider changing this patient to a LABA plus LAMA. For a patient who has a current exacerbation, but their blood eosinophil count is greater than 100, we should actually consider doing triple therapy with this patient. So adding on a long-acting muscarinic agent to the LABA plus ICS. For a patient that has no relevant exacerbation history, we want to consider changing this patient over to LABA plus a LAMA and excluding and stopping the ICS in these patients. For patients with no current exacerbation and a previous positive treatment response. So for somebody who had an exacerbation and was and we saw a response with the LABA plus ICS and they have a low symptom load, we can just continue the treatment. But if they have a high symptom load, so they had a high intense shortness of breath, we want to consider adding triple therapy and not just switching over to a LABA plus LAMA because we know that steroid helped reduce that exacerbation in that patient. So follow-up pharmacologic treatment algorithm. So this is kind of discussing different agents that we can use for patients who have experienced exacerbations and now the disease is progressing. So if they have shortness of breath and they're on a long-acting beta agonist or a long-acting muscarinic agent, we're not going to add both of those agents together. And we're going to consider switching inhaler devices, implement accurate or non-pharmacologic therapies. So as the disease is progressing, we want to make sure that our patients are being compliant with their medications and they're able to afford their medications. And then we also want to investigate other causes of shortness of breath. So is the patient also having a heart failure exacerbation? Does the patient have allergies? Is the patient at risk for COVID infection? So we really kind of want to look at all our etiologies for that shortness of breath. Now, if they're having an acute exacerbation, we have a patient with a long-acting beta agonist, and if the blood eosinophil count is less than 300, and they're just on one agent, we want to do two agents. And then if we see that blood eosinophil count afterwards is greater than 100, we want to go ahead and put them on triple therapy. And this is as the disease progresses. Now we have patients on triple therapy and they're still having exacerbations and their eosinophil count is greater than 300. We might want to include new medications. So one of the medications we could add is dupilumab, which is for patients with chronic bronchitis. And then these are for patients with a history of 2 or more moderate to severe exacerbations. And they had one in the last year despite having being on triple therapy. And also for eosinophil counts greater than 300, because this leads to fewer exacerbations and it also leads to improved health outcomes. Another agent we can add for patients who are former smokers. So not patients who are currently smokers, but patients who are former smokers who are on triple therapy, adding azithromycin to former smokers. And then also for patients who were on dual therapy and then were switched to triple therapy, the addition of roflumilast for if the FEV1 is less than 50% and the patient has bronchitis. And the issue with dupilumab is that it is an injection that needs to be taken every other week. And it, of course, because it's a branded medication, it is expensive. So one of the things that we have to do is make sure that our counseling points for our triple therapy are on point. We want to make sure the patients have the adequate inhaler and they're using it correctly before we switch them over to oral therapy or subcutaneous therapy. And then to start or not to start ICS therapy. So this was one of the biggest things that we saw in the new 2025 guidelines is that which patients should we be starting on ICS. So the patients that we strongly favor use are patients with a history of hospitalizations or exacerbations of COPD. They've had greater than 2 exacerbations in the previous year, and their eosinophil count is greater than 300. And then they also, for patients who also have asthma, we strongly do want to use steroids in these patients. And then it favors use for patients who have greater than 1 exacerbation, and then have the eosinophil count 100 to 300. And then we don't want to use this on patients because we know steroids, the ICS, are increased likelihood of pneumonia, is repeated pneumonia events. So if they have one pneumonia event, you can still use it. But if you're seeing repeated pneumonia events, we do not want to include ICS in these therapies. And then if the blood eosinophil counts less than 100, and then they have a history of mycobacterial infection. And then there were a couple trials that looked at to start or not to start ICS treatment. And these 2 trials are included in the new COPD 2025 guidelines. It was the IMPACT trial and the ethos trials. Just a word of caution on both of these trials. Both of these trials were sponsored by respective drug companies. So we kind of do have a little bit of bias when it comes to both of these drug trials. So informing the pathway of COPD treatment is the IMPACT trial. So it was a randomized, double-blind, parallel group, multi-center trial. And basically what it did, it had the triple therapy with fluticasone, your ICS, and your long-acting beta agonist. And then it also had and then they compared it to dual therapy with a long-acting beta agonist and an ICS, or with a long-acting beta agonist and a long-acting muscarinic antagonist. So basically what it showed was that triple therapy was associated with a 25% lower rate of moderate to severe exacerbation, regardless of them being on any of the other arms. So if they were on the dual therapy, triple therapy still reduced moderate to severe exacerbations. And then triple therapy also reduced the all-cause mortality compared to dual therapy in either arm. So our moderate to severe exacerbations versus the once daily dual LABA plus LAMA or ICS plus long-acting beta agonist, which the triple therapy basically said that it reduced the rate of moderate to severe COPD than any of the dual agents. And it also reduced the hospitalization in moderate to severe patients. But in triple therapy, there was an increased risk of pneumonia as opposed to both dual arms, even the dual arm that had the steroid in that dual arm. And then what we also found was that patients that were assigned to all 3 of these arms If they had a history of asthma, they weren't excluded from these trials. These patients had to have the COPD, but whether or not they had asthma were not excluded from these trials. So that is a compounding variable that can change the trajectory of this trial. So, and the other issue with this trial is that patients who were on triple therapy and then were changed to the dual arm therapy, the ICS was withdrawn from them. So they went from being on triple therapy or being on therapy with an ICS plus a long beta agonist to having them withdrawn the ICS, which led to increased exacerbations in the first couple days following these treatment arms. So because there was not a good way for the investigators to assign these groups, we found that there was a lot of confounding variables. And we know that if we abruptly DC or stop steroid therapy, that can lead to increased exacerbations. So then we had our second trial, which was the efficacy and safety of the triple therapy and the obstructive lung disease, which we know is the ethos trial. And the ethos trial had actually three different groups, which we had triple therapy with high dose steroid, and we had triple therapy with a low dose steroid, which had a dual arm with a long acting beta agonist and a long acting muscarinic agent with an ICS plus a long acting beta antagonist. So this was again a randomized double blind parallel group multicellular trial. And basically what it said was your triple therapy, high and low triple therapy versus dual therapy. And it showed that the risk of death from any cause was 46% lower in the high dose therapy versus the long-acting beta agonist and long-acting muscarinic antagonist, and 22% lower in the steroid plus long-acting beta agonist. But again, this actually was only with the treatment arm that was using the high-dose steroid versus using the low-dose steroid. And the risk of death from any cause in the low-dose triple therapy was actually lower than the LAMA plus LABA, but higher than the ICS group, because when we use the ICS group plus the long-acting beta agonist, they actually used a higher steroid versus comparing it to the triple high versus low. Those two trials were kind of used in the new 2025 GOLD guidelines to maybe justify using a steroid in patients. But we also find that the lack of efficacy of both agents, because they were comparing two different strengths of the steroids, we found that we couldn't justify using triple therapy in all of our patients. So our next knowledge check is a patient has had 2 COPD hospitalizations, so that's our keyword, 2 hospitalizations in the past year, and has a blood eosinophil count of 327. Which therapy is the most appropriate for this patient? About 86% of you guessed the Trilogy inhaler or option D, which is correct. Because the patient has a greater than 300 eosinophil count, we want to make sure we have that steroid included in our inhaler therapy. And we know for all patients in group B and E that we want them to be on dual muscarinic agent antagonist and a beta agonist. And so the other therapies that we have are antibiotics. So some antibiotics, which we include, is azithromycin, and it's proven benefit in former smokers, and it's indicated if the 3 cardinal symptoms are present. So they have worsening dyspnea, increased sputum volume, and increased purulence of the sputum. So we want to start patients on azithromycin if they're former smokers. And your empiric antibiotics choice is based most on these likely pathogens that are listed above. And our guidelines for therapy is previously we had started these patients on a Z-Pak. So we would have 500 milligrams of azithromycin followed by 250 milligrams for 4 additional days. We found that that was actually just as efficacious as using 500 milligrams for 3 days. And because this has increased compliance because you're using therapy for 3 days versus 5 days, we do prefer this in most of our patients, especially in the hospital. And then our other option is, again, Daliresp or roflumilast, which is a phosphodiesterase 4 inhibitor. And that is actually dosed by 250 micrograms once daily for 4 weeks, followed by 500 micrograms once daily with or without food. And again, this is used for our patients who are on triple therapy and have bronchitis and are still having exacerbations. So our acute management of COPD exacerbations is, what are we going to do for our patients who might be on double or triple therapy and come into the hospital and have exacerbations? So the first thing we want to do is assess if they need oxygen. So do they need supplemental oxygen to maintain a PaO2 of approximately 50 to 60 millimeters of mercury? So usually we're starting out with about 3 liters a minute via nasal cannula. Can we start them on bronchodilators? So Duodenab is really our first choice. We put them on scheduled Duodenab, ipratropium, and albuterol. And the reason we do that is because we know that our muscarinic agents are going to act on our proximal large airways, where our albuterol, short-acting beta agonist, is going to work more on the distal airways. So with our beta agonist, it's going to act directly on the muscle, whereas our ipratropium is going to reduce the cholinergic tone, which is going to give us an increased efficacy versus just using a long, short-acting beta agonist alone. And then also we can start patients on oral steroids. So prednisone 40 to 60 milligrams a day for 5 to 14 days. But unfortunately, the optimal dose and duration hasn't been established. And we know that long use of steroids is associated with a lot of side effects, notably using causing insomnia is one of the first things that we do see. And then chronic use of steroids is not recommended. So we usually want to start patients on that lower dose of prednisone and taper throughout the next couple of days instead of using a 60 milligram to start out with. Unless the patient has repeated exacerbations, we can start out with a higher steroid dose. Our next knowledge check is a 67-year-old male patient is having severe dyspnea and is admitted to the emergency department for community-acquired pneumonia. He has smoked 1 pack per day for the past 20 years and is currently using Trilogy, so our triple inhaler, to manage his COPD. How should his acute COPD exacerbation be managed? So it's A, continue the Trilogy inhaler. B, use Duonabs and supplemental oxygen. C, start IV vancomycin for the pneumonia. Or D, start dexamethasone 10 milligrams IV Q6. So it looks like 88% of you decided that Duonabs supplemental oxygen would be the most likely therapy for this patient, which is correct. We want to make sure that because the patient is in the hospital, we're going to start using nebulizers and give this patient supplemental oxygen until the exacerbation has subsided. And then we know on discharge therapy that a Trilogy ellipta inhaler is probably the correct choice for when the patient is discharged. And then also we can consider adding oral agents to this patient like Delares if they continue to have exacerbations and have a bronchitis. One of the other things that I, as an inpatient pharmacist, that I would, because of increase in exacerbations for this patient, is 1, smoking cessation. Talk to the patient about smoking cessation. And 2, and make sure the patient knows how to use that Trilogy ellipta inhaler correctly. And one of the patients that I had seen in the hospital earlier today really commanded the respiratory therapist for helping them show how to use their inhalers correctly, because they found that they were using most of their inhalers incorrectly and were not getting the most out of all their inhalers. And we were actually able to stop the oral agent because they had figured out how to use their inhalers correctly, and they were not able to afford the oral Delares. So one of the biggest interventions I tell pharmacists to make is to get a respiratory therapist and help the pharmacist, along with the respiratory therapist, can kind of go over the patient's inhalers at home and make sure they know how to use them appropriately. So some of the non-pharmacologic therapy we can use is smoking cessation. It's like our number one thing that we can do is smoking cessation, whether it be secondhand smoke or vaping, because we know children of parents who do smoke in the house have an increased likelihood of COPD as they get older, even if they do not smoke themselves. Pulmonary rehab is indicated for groups B and E, exercise training, breathing exercise, and psychosocial support. For an acute exacerbation, we want to make sure the patient has supplemental oxygen titrated to an oxygen saturation of greater than 90%. And then other things is to educate the patient on compliance. The last thing we want to kind of go over our patients is immunizations. Make sure they have their annual influenza, COVID, RSV, and pneumococcal vaccine. And then also a herpes zoster is for all of our patients with COPD who are greater than 50 years old. So our last knowledge check is to decrease COPD patient risk of getting any type of upper respiratory tract infection, minimize exacerbations, and promote relief. Which vaccinations are recommended in a 59-year-old? So most people have said a pneumococcal influenza, RSV, and herpes zoster, which is the correct answer. And the role of the hospital pharmacist is smoking cessation, making sure our patients know how to do inhaler technique, medication reconciliation, transitions of care, and education to other healthcare professionals about the latest guidelines. And again, the number one role of the hospital pharmacist is to make sure our patients know how to use their inhalers, are compliant with their inhalers, know the directions, and smoking cessation. Thank you, everyone, for your time.